welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I am a clinical professor in the Department of Kinesiology, Nutrition, and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Dr. Clint Daniels. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes reviews really helps others find out about chiropractic science. So if you like the show, please take a second and write a review. It will support chiropractors everywhere. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website by making a donation. All right, on to the podcast. Well, let's get on to the interview with Dr. Clint Daniels. Dr. Clint Daniels is Chiropractic Section Chief at VA Puget Sound Healthcare System in Tacoma, Washington, where he serves a team of 9 chiropractors and is a resident director. He serves on the VA Chiropractic Field Advisory Committee as the research coordinator, is a scientific commission board member for Clinical Compass, and is appointed to the Washington State Health Technology Clinical Committee. He is a 2010 chiropractic graduate from Logan University, where he also received his Master of Science in Sports Science and Rehabilitation. He worked in private practice for 4 years and then joined VA and was the first graduate of the St. Louis VA Chiropractic Integrated Clinical Practice Residency Program. He has authored and contributed to numerous scientific publications on the topics of chiropractic integration into veteran and military facilities, post-surgical spine pain, suicide prevention, chiropractic best practices, and numerous case reports on a variety of clinical presentations. Dr. Daniels, thank you so much for coming on the podcast.
Thanks, Dean. I'm a longtime listener of Chiropractic Science and first-time caller here, and it's really an honor to be asked to be part of this interview. You've had so many great researchers and chiropractic thought leaders on. I'm very humbled to be part of the conversation.
Well, I would say likewise, and I just appreciate you coming on the podcast, and you're doing great stuff. So we're going to learn about all of the cool stuff, or at least not all of it, but some of it. We've got a lot of stuff to get through, actually. There's some really important papers to talk about. So, but as you know, I always like to ask my guests how they became interested in becoming a chiropractor in the first place.
Yeah, happy to talk about that. I think my chiropractic origin story is probably similar to a lot of people in our profession with sort of a personal experience. I was a high school athlete. I was a wrestler and injured my neck in a practice, and it was interfering with my ability to compete. And my parents took me to the family physician, and he evaluated me and said, basically, there's nothing wrong with you. And, he was right. I didn't have a fracture. I didn't have, acute indication for imaging or medication, anything like that. However, I kept having pain and still couldn't compete. And my dad at the time was a union carpenter, and he's retired now. And he had been using chiropractors for years just to stay on the job for his labor-intensive work. And he set me up with the chiropractor he was seeing. And I think I saw him 2, maybe 3 times and was fixed. So if you're ever in Lafayette, Indiana, look up Doug Williams. He does great work. And so I had already kind of been considering healthcare as a profession or a major in college. And so I kind of continued with that, with the idea of going to chiropractic school afterwards. And I was very fortunate. I studied health sciences, and the school I went to actually had a concentration in pre-chiropractic, which was basically the exact same as the pre-med program, but they just swapped out pharmacology and toxicology for biomechanics and exercise phys. And once I finished that program and graduated, I started at Logan just a couple months later in Chesterfield, Missouri.
That's great. Well, maybe you could tell us just a little bit about your chiropractic education, and then I'm also interested in learning about your private practice. I know you're out in private practice before you got to the VA, so maybe just tell us about that transition a little bit, and then we'll certainly get into the research.
Yeah, so once I graduated from Logan, I graduated in 2010, as you said earlier. I stayed in St. Louis for a few years in the St. Louis area. I worked as an associate for a couple years and then opened my own practice, which I ran for about 2 years as well. And during that time, through conversations with one of my research mentors, Dennis Enix, who was a professor at Logan, he told me about this new VA residency program and highly encouraged me to apply to that program. And of course, I ultimately did, and was offered a spot. And at that point, I had to weigh, do I close my practice that I've spent a couple years building to take a pretty good pay cut for a 1-year position that didn't have any guarantees of a job afterwards. And I ended up taking the leap, and it's the best decision I've made, career-wise. It's just been a fantastic experience in the VA. The program itself was great, the residency, and then into my staff position afterwards. VA has a strong culture of train and retain, and so I was able to get a few interviews and ultimately land at VA Puget Sound, where I wanted to be.
Awesome. So yeah, I know Dennis. Dennis is great. So you got interested in research, it sounds like, even before you got to the VA. But I'm assuming once you got to the VA, you got into some of the studies that you've been a part of. How did that go? What exactly happened to get you motivated to do research?
Sure. Yeah. My research path really, I'd say, started in undergrad. The school I went to was a big research institution. I had a lot of lab classes and was fairly comfortable with sort of, the scientific process or research methodology in sort of a generalized sense. I got exposed to PubMed and other databases in undergrad and was decently adept at those, utilizing those databases before starting chiro school. In my chiro program, I tried to continue to develop my interest in research skills in research through, attending journal clubs and reading articles. I actually wrote my first case report as a student and published that, very shortly after graduation. And then in those few, 4 years or so of private practice, I really focused on trying to identify mentors and peers that I could work with. And I was really fortunate that Cheryl Hawk actually came to Logan to work for a couple years in that time frame. And I reached out to her and set up a meeting, and she and I hit it off right away. Excuse me. And that relationship really led to a lot of opportunities and open doors for me to kind of progress to the next level of my understanding. So I was able to do some peer review work, and I served on the editorial board for a journal that she was running at the time, and also had some opportunities to collaborate with her on projects. And then when I started at VA as a resident, residents have the great opportunity to have some dedicated time for scholarly activities. So, they can work on research projects, presentations. We have national projects that the residents do as well. And I really tried to maximize the use of that time. So during my residency, I published a case report, a narrative review, and then I was also able to collaborate on a project that was led by Bart Green and Claire Johnson. And that, working with them and with Cheryl on projects was really instrumental in molding my approach to projects and, how I looked at, not just like how evidence synthesis work is done, but how to lead a project and be successful and see these through to the end. And then once I moved into my staff position, I had, I no longer had any protected time, but I had a little more freedom to kind of do whatever I wanted research-wise, as long as it met the requirements of our facility. And I became for the field advisory committee, which is sort of the chiropractic field nationally of all the chiropractors that work in the VA, representation to central office, which is like Dr. Lisi and his team. And in 2018, I took this role as research coordinator, where I then had to start running our journal club calls and trying to foster a culture of research and evidence. And then shortly after I got the residency program, we had applied to a proposal and were awarded one of the spots. And we've really tried to continue challenging our residents to do a number of projects, one of which I think we're going to talk about here shortly.
That's great. And, I just want to reiterate something that you said that I think is really important, especially for any chiropractor that is looking to get into research. And that is just the simplest thing. You reached out to Dr. Hawk and said, hey, I'd like to, meet with you. I mean, that's how it starts, right? And you had some great mentors along the way. So that's fantastic. Now, you mentioned some of the things that you're doing with the VA. So I'm just curious, like, what would a day in the life of Clint Daniels look like?
Yeah, so at VA Puget Sound, we are on 4-10 schedules. So I technically work Monday through Thursday from 7 to 5:30. And I am clinical Monday through Wednesday, so 3 days a week, other than, I'll occasionally have a block time where I have to attend a supervisor meeting or things like that. And then Thursdays, I am fully administrative. So that administrative time is for doing all my supervisory duties and also for running our resident program, and which is quite involved. We are CCE accredited, which is something that's really unique about VA chiropractic residencies. We are currently the only accredited residency programs for the profession. There is a program in a hospital in Wisconsin, Advocate Aurora, that is also pursuing this as well, which is another great spot. And so, a lot of my time is devoted directly to running that program. I don't do any teaching other than in the clinic. I'm not in a classroom setting or anything like that. I also don't have any dedicated research time. I can use a little bit of my Thursdays to work on projects that are directly related to things my residents are doing. But otherwise, all my research work is, nights, weekends, between patients, as much as I can without my wife getting upset.
Yeah, I understand that. You do it because you love it, right? I mean, that's exactly why a lot of us do this. Yeah, that's great. And it takes a team for sure. I couldn't imagine if my family wasn't supportive that way, but it's just, it takes a lot of commitment, but yeah, absolutely. Just do it because we love doing it, and you don't have to do it. But we're going to be talking about some of these great projects. So that's the next thing I wanted to say is that, as I was looking through your research projects that you've done over the years, there's a lot there. I was trying to come up with questions. I was looking at some of these papers in advance of our discussion today, and there's just a ton. So I think we should just dive into some of these papers, and I'll probably have some questions along the way. But I want to preserve our time to actually get into the nitty-gritty of some of these projects you've been involved with. And the first one that I'd like to talk about is from a paper called The Effectiveness of Manipulative and Manual Therapies in the Management for Patients with Prior Lumbar Surgery. This is such a neat topic. What chiropractor doesn't see patients who have had prior surgery? That's the question. I think the real question maybe is how many, like what percentage do we even know? And then how do we take care of people who have had surgery? Such a great topic. So I'm glad you're a part of that. And I'm really excited to hear what you were able to come up with in this paper. So maybe you can just walk us through that.
Sure. So as it says in the title, this was a systematic review where we had a couple aims. The primary aim was to look at effectiveness of manipulation and manual therapy on pain and function for people who had prior lumbar surgeries. And then we also looked secondarily at adverse reactions and medication utilization. And so we included most all types of surgeries, with the exception of people who had surgery for scoliosis. We considered that to be a different of enough condition and did not include that. So what we did include was, discectomies, laminectomies, fusions, disc replacements, spinal cord stimulators. We also included all manual therapies that we could find. So, spinal manipulation with, HVLA, flexion distraction, instrument type techniques, drop table, stretching, massage, PIR, PNF, occupational manipulation, or not occupational, osteopathic manipulative therapy. And then we graded the evidence of the RCTs that we included, and also the systematic reviews, and those are what we use to form our comments on effectiveness. For the adverse reactions and medication utilization, we also included lower level designs. So, excuse me, things like cohorts, case reports, case series, things like that. And then in the paper, we broke all of this down by surgical type. So, if a patient's had a fusion, what's the evidence say on manual therapy for that? And, we also included the lower level studies to give more context, because we were anticipating we wouldn't find many higher level studies, many of those RCT type designs. And we were glad we did, because that was pretty much true. I think we only identified 4 adequately powered RCTs, and several of those were quite old, and they were all very different, very heterogeneous. So, different timelines of care, different treatment approaches, different, populations, different, like they had prior surgeries were different, or maybe a combination, or maybe they didn't differentiate them at all. So it was really not possible to put them together for any kind of meta-analysis. And, so when we were all said and done, basically most of the surgical types, we really couldn't say, whether or not to recommend or discourage manipulation or manual therapy in general for each of those. So, really, I think this was basically just meant to be sort of the first systematic review work on this to identify gaps, and hopefully, future designs will look at this deeper.
Yeah, for sure. And like you say, this first attempt, but a really important topic. And again, something that, chiropractors see, these patients who have had different kinds of surgeries, I'm presuming on a daily basis and multiple a day probably, that have had various kinds of surgeries. So I think you made a great point in the discussion. I'm just going to share it with everyone, because I think it hit the nail on the head. So in the discussion, you say this growing subpopulation of low back pain sufferers, that is, people who have had surgery already, and thus the interested clinician is forced to rely heavily on case reports and series for literature guidance. This to me strikes me as, one of these evidence-based practice dilemmas, right? We have 3 legs to the stool. We've got the clinician's experience and thoughts, expertise. We've got what the patient is valuing, and then we have to consider, of course, what's in the literature. But in this case, there's not a whole lot to go on. And your paper now is the highest level with this review. So it's something that we all encounter throughout our practice careers. And you have to make some sort of decision, right? I mean, these people are coming to us. They have pain still. They've probably tried many other things other than surgery, I would guess, injections and medications and whatnot, massage, and so many things that people try. And so it really comes down to, from a chiropractic standpoint, what is it can we do, and what kind of guidance can we rely on? I am curious do we have any idea of what percentage of patients that chiropractors see who have had prior surgery?
Yes, actually. So until very recently, I would have said no. We just didn't have any data. I had done a survey a few years ago where we surveyed VA docs on just fusion and what they do with them, how often they see it, and we know chiros report seeing these patients. As you said, you're seeing them too, and I think in our survey, about 90% of the respondents had said they'd seen a post-fusion patient within the last month. But that's, obviously subject to recall bias and is not, good data on like how often we're really seeing them. But just this week, I came across a paper that was just published in Curious, which is Curious, by a friend of the podcast, Rob Traeger. And in this study, they looked at the TriNetX or Trinetics, I'm not sure how you say it, database, which includes 110 million patients. And these are all patients seen in academic centers. And of those, they identified 80,000 that were receiving chiropractic spinal manipulation. I believe they use CPT codes for that. And of those, like 10 to 11% had prior surgeries also coded. So that's, to my knowledge, that's the first study that has presented data on how frequently we're seeing these patients. So, 1 in 10 essentially has a prior surgery, at least in academic centers. So, that might not be perfectly generalizable to private practice because obviously most chiropractors are not working in academic centers, at least in the U.S. So I was pretty excited to read that paper.
Yeah. Shout out to Rob Traeger. Great job on that.
Yeah,
and
great guy.
Yeah, for sure. And I think that that the discussion needs to continue a little bit further with this paper. Just diving into some of the details. At least I'm just going to shout out a few things that I thought were really quite interesting. So, one of the things you mentioned in the paper was that, patients who have had prior surgery who see a chiropractor would typically have, some mild soreness, but there were no serious adverse events that were reported in the case series or, any of the studies that you had come across. And I guess, that did strike me as kind of interesting, right? Because these people have had already invasive surgeries, presumably. And so it kind of made me think, well, I wonder if they might be predisposed to having a little bit more, of a significant pain or issue, but apparently not. So that was nice to see. I don't know if you have any comment on that, but that just struck me as, wow, that's pretty interesting.
Yeah, we were a little bit surprised and very happy to see that. None of the RCTs, none of the case reports, nothing had any serious adverse events reported. Maybe that's publication bias too, and just people didn't write up the adverse events. But I feel like usually there's no shortage of ER physicians and other physicians willing to write up any adverse event that can be linked to chiropractic. So, or to spinal manipulation in general. So we were really happy to see that finding.
For sure. Now, one of the things that patients, either, potential patients or patients in my own practice ask me about is whether they can receive chiropractic care after lumbar spine surgery. And, it's an interesting thing. Like, the patients say, well, should I ask my medical doctor or can you tell me, this sort of thing. And it's always an interesting thing when I hear people ask that question. So I'm curious what your thoughts are on that. Is there any kind of general advice, or does it all just come down to just, the individual, what they present with? That's usually how I kind of approach it, but maybe there are some sort of general pieces of advice.
Sure. Yeah, I think this is a really good question, and something I see debated a lot when I talk to colleagues, and even when we've done like the survey project that I was part of, and I was part of another project with Rob Traeger where we looked at individual patient data just in all the cases. And there's lots of different approaches people are taking with people have had surgeries, whether they are or not comfortable with doing HVLA, or they'll stick to just flexion distraction or other approaches. And I really take a very patient-centered approach. I think you hit the hammer on the nail there. And it really depends on their presentation. So I think for somebody who's had a surgery that has had adequate time to heal, I usually like to see them, if I'm considering spinal manipulation with HVLA, I'm wanting to see them 9 to 12 months after the procedure, just to make sure things are as healed as much as we can, and not putting undue risk to the area. And that 9-month number that's basically the earliest you'll start to see signs after a fusion, signs of calcification on an X-ray. So that's sort of where that comes from. I've had some conversations with neurosurgeons where they think that's actually maybe too conservative, and could do more like 6 months without too much risk. I think it matters a lot, though, what the patient's comfortable with. I've definitely had people who've had maybe a cervical fusion who've said, I don't want you to mess with it. And we say, okay, no problem. We'll work on other areas. I think generally I also, for a lumbar case, I want to see some flexion extension films after a surgery to make sure the area is stable. And then, it depends on the symptoms. So, if they have a bunch of neuro findings, I'm going to be way more conservative versus if they just have, mechanical back pain, but also happen to have had a prior surgery.
Got it. Yeah. Yeah. Those are great pieces of advice. No, just curious, the 6 month and the 9 month that you were talking about, waiting after surgery, I'm assuming that would be for a high velocity type of manipulation. How about like soft tissue type of work?
Yes, you're spot on there. For soft tissue work, I'd probably wait 6 weeks or so, just for normal tissue healing, and make sure they're kind of through that window of high infection risk. I did see a case report that was published recently on, I think it was last year, on cervical disc replacement, where they manipulated in the area pretty quickly, like within a month after the procedure. And the patient had a good outcome. And I've seen, some discussions and arguments where, for disc replacement, maybe we should be involved in mobilizing and doing things earlier, where it's going to be a different approach for like a fusion where you want stability. And those I would be less inclined to get too aggressive with. I also think you could do like core strengthening pretty early with a lot of these cases, or manipulate other areas. So, I don't see why you couldn't do, if they're having other pain complaints, I don't see why you couldn't do manipulation of the thoracic spine or cervical spine after they had a lumbar procedure. I don't think that's going to put them at too much undue risk either.
Sure. Yeah. And I guess the mechanical person inside of me says, yeah, and those may have an effect on the more distant segments anyway. So may not be a bad thing just to check the whole spine. There's more than just the lumbar spine or the cervical spine. I mean, there's more segments. So, they could certainly benefit perhaps from care elsewhere. And that brings me to another question that I had. There's debate, I think, within our profession as to, do we actually adjust the segment that we think we are? I guess but that's not the real question I wanted to get to. The question, I guess, might be more like, in this context of surgery, should we be, manipulating a segment, let's say, that has fusion, or 2 segments away, 3 segments away? I mean, was there any discussion of that in the papers that you read?
Essentially, no. I have not found any literature to say like we shouldn't do, based on evidence and not just opinions anyways, that say we shouldn't do manipulation to an area of fusion. I think some of the confusion around this comes from, I know this was my stance anyways coming out of chiro school, thinking that the hardware and all the nice stuff that looks beautiful on an X-ray was the fusion, and that's actually not correct. The fusion is the sort of the healing of graft material in the disc space, that's usually in some sort of cage, and once that heals, that's one bone. So the idea that you're going to break apart a fusion that properly fused, I think is very unlikely. So I personally think it's reasonable if the patient can tolerate it, and you preload the area to do manipulation, including hands at the site of where the fusion was, because you're going to move the joints above and below it anyways. To kind of get at your first question, we're not moving a single joint; we're usually moving whole segments. So I don't have any issues with doing manipulation to the area of a fusion if patient-centered, if the patient can tolerate and wants the treatment. I am aware of out of a group out of RAND UCLA released an expert panel paper a couple years ago. And in that, they looked at clinical scenarios where spinal manipulation was not appropriate or where it was appropriate for chronic low back pain. And one of the things that came up consistently in that was laminectomy as potentially not appropriate for spinal manipulation. And I think they're probably thinking, total laminectomy where you're moving a large amount of bone and changing the biomechanics. However, it's not really clear where they came to that conclusion from. I haven't seen any studies that specifically call out laminectomy. And we in our systematic review, we found a lot of case reports and other, I think there were more case reports actually on laminectomy than any other surgical type. And, it was saying no adverse reactions or anything. So at this point, I don't think we have any evidence in the literature that says, we shouldn't do manipulation.
Yeah, well, great answer. Very similar to how I approach patients with prior surgery. And, the way I kind of think of it is similar to you. And I would extend it and just say, what's the difference if somebody's had, osteoarthritis at a particular segment and it's fused naturally, so to speak, for a number of years. I mean, it's fused. And so, I haven't heard too many people suggest don't manipulate or don't try to do anything around those segments at all. I've never heard that. So,
yeah, I think a good analogy is like if you break your arm and you cast it and it heals back, it's now one bone. Like you're not like putting some stress to that area isn't going to re-break it unless you put a huge amount of stress in,
right?
Which we're not doing anyways.
Exactly. Well, I'm enjoying this discussion so far, so this is good. Excellent. Thank you. Okay, let's go to our next paper here, and this is, to be honest, this is not something I think about a whole lot, but it is it's a very important topic. And this is from the Journal of the Canadian Chiropractic Association, The Chiropractor's Role in Primary, Secondary, and Tertiary Prevention of Suicide, a Clinical Guide. So, I wonder if you could guide us through that. There was a lot of practical stuff in the article, which I really appreciated, a lot of websites. So just putting a plug out there for chiropractors in practice, if you need to look up any of this information or you want websites to help your patients, check this out. The JCCA article is free full text. So just wanted to say that in advance. But Clint, take it away.
Thanks, Dean. I appreciate you saying that because that was really the intent of this paper. Was we wanted clinicians to be able to just print it off and have it in their office, and if they need to run to it real quick with a patient who's in need, they've got it available. This paper was part of a series of papers that I did with a VA colleague, Zach Coupler, and suicide prevention is something that VA providers are very keenly aware of, and we have a lot of resources at hand for this. That series of papers we put together was essentially a call to action to our profession that we published in Chiro Manual Therapies, this guide in the Canadian paper or journal, and then we did an educational paper where we're looking at what's being taught at colleges, residencies, CE, that kind of stuff. And then we also did a case series that I would point clinicians to as well. That was, I think it was published in Journal of ChiroMed, where we gave some examples of how you can work with a mental health provider, and then what the mental health provider might do with the patient once they actually see them. So you can give the patient an idea of what to expect before they get to that next provider. And, so the reason, all of this it was so important to Zach and I is, as I mentioned, it's a big part of the VA culture to be aware of it. But suicide is the 10th leading cause of death in the U.S. And major risk factors for suicide are chronic pain, opioid use, and PTSD. And, in VA, we see a lot of patients with PTSD, but I think all chiropractors are seeing people with chronic pain and likely, have had prior opioid use. So, this is something we felt was very important to dive into, and was another topic where we couldn't find much in the chiropractic literature that was relevant. And so we wanted to try and put that together for ourselves and for others. And the idea was to make us less anxious in addressing this, and be able to help those people in need. So with this particular project, this was a descriptive review. So it's not as methodologically rigorous as that systematic design. But we really, our goal was not to have a finite PICO for an answer we were trying to come up with, but rather to create a digestible guide that would actually be useful to people in practice. And so in the paper, we review some of the accepted terminology, around suicide, in that's up to date. We also dispel a lot of common myths around suicide and suicide prevention. So, for example, a lot of people think that by asking patients, about, thoughts of self-harm or thoughts of suicide, you might actually somehow trigger them to attempt suicide or to, accidentally, inception thoughts of suicide into them. And we know that that's absolutely not true. That is a myth. Asking patients about thoughts of self-harm actually reduces the stigma around it and opens the door for them to reach out to you for help. And chiropractors are very well positioned for this because we tend to see the patients fairly frequently and build really strong rapport with them, maybe better than they can build with their primary care provider that they see, once a year or every 6 months kind of thing. I think breaking down some of those myths is important. And then, for the rest of the paper, we basically categorize prevention measures that can be taken at a primary, secondary, and a tertiary level. Primary measures is looking at things like social determinants of health, and some of these things are modifiable, some are not. Not modifiable might be like a family history of suicide, serving in the military, being a sexual minority. Things like that can be risk factors, but are not things that you can change. Modifiable things is going to be like treatment adherence, substance abuse, things like that. And then we also dive into protective factors. So, having strong social supports, family connectedness, things like that, spiritual beliefs, all of those can be protective against someone attempting suicide or reducing the chances of having thoughts of self-harm. Then from the secondary standpoint, I think this is the one that's probably, secondary and tertiary are probably going to be of most interest to chiropractic clinicians, which is screening people who are having or potentially having thoughts of self-harm for the secondary. So we go through a number of different assessment tools that are available. In our clinic at VA Puget Sound, the way we do it, we have intake paperwork the patient completes, and as part of the review of findings on there, they have a number of mental health questions to answer, which is basically, are they having depression, anxiety, PTSD, thoughts of self-harm. And if they select yes to any of that, that's sort of their first opportunity to tell us, they want to talk about it. And so if they mark yes, then we ask about it in our patient interview. And, if it's not something already being managed through mental health, which, fortunately in the VA, commonly they are, then we'll run a Columbia Suicide Severity Rating Scale, which is, we've got a tool for it that's really easy to run in the electronic health record system. And that's essentially a 3 to 8 item tool, and depending on their answers. So, if they say, no to the first couple questions, the survey is really quick. And at the end, it tells us what to do with the patient. So, if they're having active suicidal ideation, that's somebody that we're going to very quickly plug into the primary care mental health team and get them help. Or, we could even reach out to we have a veterans crisis line here locally that we can reach out to plug them into. If it's more passive, then maybe it's just setting up a consult with a psychologist or psychiatrist. And then from a tertiary standpoint, this is the people who are having, active suicidal ideation or have previously, attempted suicide. And so this is going to be a lot of resources that I think will be really useful to the clinicians. We have some really nice appendices at the back of the paper that both for the US and for Canada that give, phone numbers and hotlines and online forums and all sorts of places you could direct the patient to very quickly and get them some help.
Yeah. I was really impressed with the appendices. I thought those were fantastic. So I think you're right. People in practice are really going to find that quite useful. So people in practice then, I know that through the VA, it sounds like there's quite a team that's available. People in practice, would you suggest maybe just reaching out or getting to know a psychologist or psychiatrist in your area type of thing and refer to them? Is that what might be a good suggestion? Or
yeah, I think that's a great, I think it probably more so in private practice than in integrated settings. You need to have some resources lined up for when this happens, and you want to have them ahead of time, not after the patient in crisis presents. Another resource I would direct at least U.S. Providers to is you can just dial 988, and I think you have to press number 1 after that, and that is a suicide crisis line that was put together by SAMHSA. So there's you can have someone on the phone right away. Just the number's 988. And you could, that's something that if I was in private practice, I would call it with the patient in the room, and then have that guide. Does this person need to go to the hospital or some other involvement? Yeah,
perfect. Well, I appreciate you going through that. It's really important topic for sure, and I really can't think of too many times in practice where I've had suicide come up, but I want to be prepared, like you said, in case it does in the future. So just having these relationships is really key.
I would say,
yeah, go ahead.
I mentioned briefly, chronic pain and opioid use are risk factors for suicide. So I suspect it actually is happening in patients more than we think. These thoughts and harm. That's why I would advocate people add a question in their intake paperwork at minimum that can be an open door for the patient, because these are people that are hurting and do need support, but maybe won't even think to bring it up to a chiropractor because they think it's the back doctor, unless some sort of door is open for them.
So yeah, perfect. Now, out of the survey, you went through some of the survey items, and it sounds like kind of a yellow flag, what some people might call a yellow flag, to follow up on. And would this be a question something like, have you ever had any thoughts of self-harm? Something like that?
Exactly. Yeah. We just have like a yes/no checkbox, and it's like, I'm trying to remember the exact wording now, but it's, have you recently had thoughts of self-harm?
Okay.
And then if they mark yes, that's when we follow up. Or if they say something offhand during the interview, that might trigger us to run the Columbia Suicide Severity Scale as well.
Okay. Yeah. Great advice, and practical, that people can start using right away. Let's get to our next paper. Also very interesting paper. This is a systematic review of guideline recommended medications prescribed for treatment of low back pain. And this came out in Chiropractic and Manual Therapies in 2020. So I wonder if you could take us through this paper.
Yeah. So in VA, we're very fortunate to have full access to patients' electronic health records. So we can see, progress notes, imaging, labs, and also their medications. And we found that our trainees, when they come in, often have very little knowledge or limited knowledge of medications commonly used to treat spine complaints. And that becomes aware to them, when they see the chart, and now you have full access to this, where, in private practice, you're kind of relying on the patient and how good of a historian they are. And, just to clarify, I was the same coming out of chiro school. So I also had limited knowledge on this topic. And when our first resident started with us in 2020, Morgan Price, we wanted to do a project, some sort of systematic review. And we finally developed this project where we looked at just what is actually recommended for low back pain as far as medication treatment. So we only looked at clinical practice guidelines from the prior 5-year period. So there's some debate on if clinical practice guidelines are outdated after they're more than 3 to 5 years. So we only looked at the most recent stuff, and we found 9 clinical practice guidelines that met our inclusion criteria, which again, they had to be about oral medication. So no injections, no other treatments. And within that, we found 10 different classes of medications that were reviewed. And we looked at both acute and chronic low back pain and what they recommended for both of those. We tried to do subacute, but the guidelines didn't include subacute, or they included it with acute with no difference. And, our big winner in both the acute and chronic low back pain was NSAIDs. Those, ibuprofen, more or less, those, or Motrin, that was what was recommended for both acute and chronic by the majority of those 9 clinical practice guidelines. And then it got way murkier after that. So for acute low back pain, the next most recommended guideline was skeletal muscle relaxants. However, that was mostly actively recommended against for chronic pain. And for chronic pain, the next most recommended medication class was antidepressants, which we found interesting because that's, obviously off-label use. And, for both of those, the antidepressants and the muscle relaxers, about as many guidelines recommended against or were inconclusive as recommended for it. And then it just went down from there. And several classes of medications were actually recommended against only or inconclusive, and no medications recommended, like antibiotics, anticonvulsants. So that's like gabapentin. And there were a couple other benzodiazepines and steroids were not recommended by any of the guidelines for acute or chronic low back pain. And sorry, I should have clarified, for low back pain, we were looking at non-radicular low back pain, so no radiculopathy cases or guidelines were included for this project.
Got it. Yeah. So if there's any patients listening, the radiculopathy just refers to no pain essentially beyond the back and buttock, so none in the leg, basically, is what we're talking about there. And so with the types of medications that are included in this paper, and finding that non-steroidal anti-inflammatory drugs were the most frequently recommended, many of those tend to be non-prescription, available over the counter. And so this I've always had an interesting, I think about this a decent amount, especially, patients will ask us, well, what do you think I should be taking? What kind of medication? And I'm sort of the same way as you. When you first got out in practice, I guess I think to myself, well, it's not really in my scope of practice per se to recommend medicines, although they're over the counter. So I do find myself shying away from some of these discussions, at least in any kind of significant detail. But at the same time, it is important to know what people are taking, right? Because there was a paper fairly recently that suggested that a good number of patients are coming to us because of the side effects of some of these medications. So, we have to be knowledgeable about the medication. So just wondering, what your thought is, like how detailed would we or should we be getting with this, and how might your approach be to a patient, let's say at the VA or just in private practice?
Yeah, I think again, I think we're on the same wavelength, Dean. In the paper we comment on a couple surveys where a lot of, or not a lot, a number of non-prescribing providers, chiropractors, said that they do give advice on over-the-counter medications, and we were a little bit surprised by that. That's something that we generally try and stay away from as well, and generally will, instead direct the patient to the prescribing provider or to their primary care. We will, discuss, just what the guidelines say with the patient, but we don't, discuss dosage or things like that. In the paper, we also, in addition to just saying what was recommended or not, we also provided, common potential harms from the medication. So the idea was that this might help clinicians to recognize, some of these side effects or what could be side effects, to where maybe you could just counsel the patient on potential side effects as that way they recognize it if they start to have them. But generally, we try and direct them to the prescribing provider.
Yeah, I like that. I'm glad we're on the same wavelength. Sometimes you're out in practice and you think, I wonder what other chiropractors are doing. So it's always very helpful to have these kinds of conversations. And I'm just going to reiterate something that was in your discussion, or in your conclusion rather, because I think this just summarizes it very well, and just want to make this key message again. So in the conclusion, it says, to manage acute and chronic low back pain, non-steroidal anti-inflammatory drugs are recommended as first-line medicine or medication, whereas no clinical practice guidelines recommend antibiotics, anticonvulsants, benzodiazepines, or oral corticosteroids. Little agreement amongst practice guidelines and recommendations for antidepressants, acetaminophen, opioids, including tramadol, and skeletal muscle relaxers. I do find that interesting because I have to say, at least around my area, the common strategy that I see, people coming acutely, especially for coming from their physician, would be pain relieving medication as well as muscle relaxers. So I don't know how common that is. Maybe that's just a regional thing. But and you had mentioned, off-label usage. It just seems like there's a lot of variability with medication prescribing. I'm sure like there is within our own profession of, different chiropractors using hands-on instrument adjusting and all sorts of things. But it's interesting and valuable for us to know.
Yeah, something that struck us as well with doing this review is I think a lot of the discrepancy between the recommendations is because the evidence itself is pretty thin for medication management of back pain. For example, acetaminophen was recommended by a couple of the guidelines, and most of the guidelines all cited one RCT, and that RCT found that acetaminophen which is Tylenol, was no better than placebo for pain, function, basically any of their primary outcomes they were looking at. And they were also using it at the maximum dose you can use in a day, which is, I forget it now if it's 3,000 or 4,000 milligrams, which is quite a big dose. And it still was, essentially no better than placebo. But I think a lot of these guidelines still consider it because it's very inexpensive, it's very available to the patient, and it's considered to be relatively low harm, even at that high dose. There's some liver risk, but it's it's not thought to be like a major source of adverse events. So some of the guidelines chose to go ahead and recommend it, where others said it's inconclusive or recommended against because there was no evidence to support. So there's sort of different takes some of the guidelines or different approaches some of them take to making their recommendations.
Yeah, very good. I appreciate that clarification. Well, let's go on to our last paper for today, and this is the role of chiropractic care in providing health promotion and clinical preventive services for adult patients with musculoskeletal pain, a clinical practice guideline. And this was published in Journal of Alternative and Complementary Medicine in 2021. A very important paper, like all of these are. and one that I personally love talking about. Anything has to do with health promotion and performance and whatnot. So I know chiropractors will be quite interested, and there's a lot to talk about in this paper, to be honest. I mean, there's no way we're going to be able to get through it all, but I wonder if you could maybe hit some of the highlights, some of the things that, high level things that maybe chiropractors should be thinking about in their practice. So yeah, if you could just get us started on this, and we'll see where it leads to, Clint.
Yeah, you're right on with, this was a huge paper, covers a lot of different topics. We could probably do 1 or 2 hours just on this paper alone. This was a really tremendous document that was completed by Clinical Compass, which, full disclosure, I'm a board member for, and was masterminded by Cheryl Hawk, who has, a long career of working with health promotion, disease prevention, wellness, kind of aspects of healthcare. And, similar to the medication review and the suicide prevention guide, we wanted this to be a resource that clinicians could use. And there are a number of appendices for this paper as well, and an online clinical guide on the Compass website too. And, so what we did for this project was we worked with a health science librarian and ran a 2-stage systematic review. So in the first stage, we looked at for just clinical practice guidelines on, the topics of health promotion, disease prevention, diet, physical activity, obesity management, tobacco cessation, immune response to manual therapy, lifestyle factors, lots of different, health promotion topics. And then for topics where there was no specific clinical practice guideline, we then looked for systematic reviews on the topic. And then we rated the evidence and used the evidence from the high quality rated CPGs and systematic reviews to develop what's called seed statements. So these are basically seed recommendations that are all based on the evidence. And then once those are ready, they are sent to a modified Delphi panel, which is a large panel of experts in our profession. And they rate each of the statements with a Likert scale, and then add comments and recommended revisions, or tell us where they think we missed something, or we overstated, or whatever. And for a statement to be included in the final document, it has to meet 80% agreement across all those experts. And so that's sort of the genesis of the project. Excuse me.
Yeah.
And yeah, go ahead.
Well, no, I was just going to say, for those of you who are, interested in taking maybe some first steps into research, you had just mentioned the Delphi panel, and this particular paper had 65 people on the panel. I mean, chiropractors in practice, I'm sure some academics. I remember looking at it and recognizing a bunch of the names of the individuals who were on this panel. Who are recognized. And so it might be a good way for a chiropractor in practice just to start to get their feet wet, so to speak, being a part of a panel. So sorry, I didn't want to detract from what you were saying there. I just, that's what came to mind.
Yeah, I totally agree. It's a great way to learn and contribute without, being the one with the name on the byline at the top who's responsible at the highest level for the work. It's something we're always trying to find good people and experts to contribute to those things. I think that sort of the main takeaways from this paper is I would want mostly just practicing chiropractors to be aware of the paper. And this is another one I would recommend having printed off in the office or digitally, where you can reference it when you need it for a given patient. It's very unrealistic that everything we cover in this paper is going to be addressed for every patient. We don't have 5-hour visits to do all that. But there are very practical tips and recommendations in there that could be used for a given patient. So, if you have a patient trying to quit smoking, you could direct them to, a tobacco cessation, phone line, which is in the U.S. is 800 Quit Now, or, direct them to, reputable resources like CDC if there's a disease outbreak, or counsel them on chronic pain, chronic musculoskeletal pain, and that cure is not the model we're working with, but instead we should be focused on function And as chiropractors, I would recommend we use our passive skills, our manipulation or manual therapy, as a tool to push them into active care and self-management. And so there's there's a lot of different things that could be applied to the right patient.
Yeah, I think we're 100% on the same page in terms of, using our hands-on skills to get people into a position that they're better able to take care of themselves. They move better, hopefully, with less pain, and then they're more capable of doing all these other preventive actions. When you feel better, you tend to eat better. You feel like you can move your body more and get some exercise. So it's really critical stuff. And so I'm glad that you went over that in a high level. You mentioned smoking cessation. What are just a couple of other of the bigger topics that the people could find in this review?
Yeah, there's discussion on just when screening should be done. I think is something that's quite useful. So we rely a lot on the U.S. Preventative Task Force, and they give really nice. That's another resource I would highly recommend field clinicians become familiar with. But it gives exactly when different screenings should occur, and maybe the chiro isn't the one that does them, but maybe you can promote them seeing their primary care at a certain age limit, or if they are a certain BMI, there's different recommendations. There's also dietary recommendations. There's physical activity recommendations. I think we discussed suicide prevention very briefly. There's a lot of different things discussed in the paper.
Yeah, no doubt. And since it's through the Clinical Compass, I think this is also free full text. Is that right?
It is. Yep.
Okay.
And, at the time we published, it was Journal of Alternative Complementary Medicine. It's now Journal of Integrated or Integrative. I can't remember. Complementary Medicine.
Oh, okay.
So if people are looking for it and can't find it, that might be why they changed the name of the journal.
Got it. And I believe last time I was on Clinical Compass, I think all of the guidelines are available on the Clinical Compass guideline or Clinical Compass website as well.
Yeah, our goal is for those to always be open access. So you don't have to be at a VA or an academic institution to read them. Great.
Yeah. So if you're out there and you're looking to find this paper, you'll just, type it in and you'll find it. And I'll make the link to PubMed at least available on the Chiropractic Science website so that you can find a link to all of the papers that we talked about today. So, Dr. Daniels, this is a great discussion. Lots of really, practical points that we're talking about today. And I want to ask my last question. Well, it might be my last. We'll find out. But usually I wrap up with chiropractors and researchers telling us about, how they might help practitioners and students pursue research careers in this field. And I wonder if you could offer any advice to these aspiring chiropractors or students who wish to become scientists.
Yeah, happy to. And I don't know if I mentioned it before, but I wanted to clarify. I am not a trained researcher, so I don't have a master's in research or PhD. But I'm I like the term clinician scientist. I think it sounds fancy and makes me feel important. And so speaking first to budding clinician scientist, I would say just keep it simple. Don't feel I think a lot feel pressure to create really elaborate designs or RCTs or things like that. But I would focus on sort of what's already in the scope of your expertise and push them to realize that developing research skills is a process, particularly for clinicians, because we are not in a scaffolded designed research program where we're learning all the steps. So it's going to take time. And I'm a huge advocate of case reports as a first project for clinicians. They're very accessible. You already have the patients to potentially write them on. And there's great guidelines available. There's the CARE guidelines that give you step-by-step everything that should be in a high-quality report. There's also a really great paper by Claire Johnson and Bart Green on how to write a good case report. So I usually push, VA providers that reach out to me to do that first. And I think it's a good eye opener to how much work research is as well. Is even, case reports that people tend to think, are low level evidence, to do it well is still a tremendous amount of work. So I think it's a great litmus test to see, is this a passive interest or is this something you actually want to dive into? For students, they have more pathways available than we've ever had as a profession. Of course, one option is more grad school, master's, PhD kind of thing, or we also have wonderful postgraduate fellowship programs that are opening up all over the country, that are either open to chiropractors or specifically for chiropractors. So, there's a program at University of Washington near me in Seattle, Yale, Harvard, Dartmouth has got a new program, Duke's got a new program. There's also VA advanced fellowships, which are very research focused in different specialties. And I think if I had to do everything, if I was graduating now and had to do everything over again, I would pursue or recommend pursuing the VA chiropractic clinical residency first to become, as good a clinician as I could in a short amount of time. And then I would consider pursuing one of those other postdoctoral fellowships and then just see where it took me from there. And then, my last just general advice for anyone looking at research is you have to have fun with it. And if you don't enjoy or aren't connecting with the project you're working on, it's going to be grueling to see it through to the end and complete that project. And actually, Dean, that's a great segue for something here. Would you indulge me a minute for a couple very quick jokes?
Sure.
All right. So
I'm just intrigued now. This is great.
All right. So first one here. What kind of dogs love car racing?
What kind of dogs love car racing? I don't know, Clint. What kind of dogs?
Lap dogs.
Oh,
Sorry, this is a lame joke. Number 2, cosmetic surgery used to be such a taboo subject. Now you can talk about Botox and nobody raises an eyebrow. And number 3, another one, you might know this one, Dean. Where do spiders seek health advice?
Oh, I have not heard this.
It's WebMD. And, yes. So, Dean, those jokes are admittedly terrible, but like any good researcher, I'm going to cite my source. So those jokes are courtesy of my good friend, Jordan Gleet. And I know Jordan's going to listen to this. And so, Jordan, I just want to tell you, I've accepted your challenge. And now I want to publicly challenge you to come on Dean's podcast and discuss your work. Dean, thank you so much for indulging me.
I love it. I love that. Yeah. Well, I wanted to get back to the idea of the, what the advice. You had mentioned, again, I think it's so important. You just have to, when you're starting, you have to reach out. You need some kind of resources. So you reached out to Cheryl Hawk, for example, Dr. Enix, and various others. And that's such a critical step. It's a simple step, but it's probably the most critical. And I think that people will find, for example, you and I, I'm sure I'll speak for myself, but I know probably for you too, that you are, I'm sure, very welcoming of people who have questions out in the field or whatnot. We try to answer and help people, get to the right place. If they have an interest in a certain topic area, maybe start seeing if there's any chiropractic research done on it, find out who the researchers are and contact them. It's somewhat simple. I don't want to make it too simple, but I would say that most of us are pretty easy to correspond with, and hopefully that can be a segue into getting into case studies or even higher level designs if that's what you want to do. But I tell you what, this has been a great discussion, Clint. Any last thoughts or jokes?
No more jokes. Those were not worthy of more. I think what you just said was wonderful advice. Reach out. Me or other researchers. I think it's chiropractic research is a fairly small community, and from what I've seen, it's been very welcoming to people who want to participate. I think research, a source where you can connect with the researchers directly is ResearchGate. A lot of people are on there. It's an easy way, for chiropractors who maybe don't have institutional access. You can contact researchers there and ask them for, a copy of their paper directly. And a lot of times they can share that with you. So that's one other little plug. And then lastly, something that I think is underappreciated is having a peer group who's similar. So, I've had, really fortunate, strong mentors to work with, but I've also had really wonderful peer support of people at a similar stage, people that I can ask my dumb questions to, where maybe I don't want to embarrass myself to my, my mentor. So I'm like, see where you can bounce things off a little more easily and see if they're experiencing the same thing. So I would strongly recommend finding peers to work on projects with.
Great. Well, Dr. Daniels, thanks again for coming on the podcast. It's been a pleasure.
Thank you very much, Dean.
Well, that was a really fun interview with Dr. Clinton Daniels. I look forward to bringing you more great interviews in upcoming episodes. Stay tuned.